Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and subsequently all other infections in between. This is the week of March 20th, 2023, and our questions this week run a very wide gamut from some COVID stuff to all sorts of other fun stuff. So without further ado, first question. With the recent extreme cycles of rain and dust storms statewide paired with mask wearing waning, that's a mouthful, do you think we'll see an uptick in valley fever cases? Yes. Great question, and 100% yes. As I think we all are familiar, Coccidioides immitis and Coccidioides possidacei, both subspecies, are special gifts of our lovely southwestern part of the country, and the I-10 corridor between Tucson and Phoenix is ground zero for highest density of those spores living in our desert soil. As we have had rains, then also the windstorms associated with that, dust gets lifted, we breathe in the spores, and that creates pulmonary coccidioidomycosis. So, yay, great, wonderful, fantastic, that's how that happens, and there certainly have been epidemiologic trends seeing bursts of valley fever cases following especially wet winters and summers, and also specifically following the various dust storms or haboobs that seem to come through. So as I think we all know that the last several months have been wetter than expected and also much windier than expected, to wit all the horrible allergies we're all facing right now. So I think it is reasonable to be looking for new onset valley fever cases in the very near future, if not already. In fact, I have seen an uptake in referrals to my clinic as well as evaluations performed in emergency departments in patients presenting with erythema multiforme and erythema nodosum, which are the two hypersensitivity rashes which correlate very strongly with acute coccidioidomycosis. Quick input for those who are currently studying for boards or maintenance certification exams. The correct board's answer is, when you see a patient with erythema multiforme, the most likely associated infectious disease worldwide is herpes simplex virus, is HSV, not cocci. But clinically and practically speaking around this part of the world, cocci is your number one. So yes, we're already seeing an uptake in valley fever, most of which, remember, will be asymptomatic or non-specifically symptomatic, such as persistent dry cough, perhaps a couple days to a week or so of flu-like illness, unexplained fatigue, which, as you all well know, correlates strongly with that associated with COVID-19. So to this questioner, thank you so much for bringing up the issue, and for everybody, do add in testing for cocci as part of your diagnostic approach to that patient who has a range of non-specific symptoms and or some respiratory symptoms that are a bit more persistent than you'd like, and certainly for those patients presenting with erythema multiforme, serum sickness reaction, erythema nodosum. Importantly, because it is frequent for us to consider a short burst of steroids in those patients who are miserable with a serum sickness reaction, E. multiforme or nodosum, do keep in mind that steroids in the setting of acute coccidioidomycosis is not a good idea. And I've equated it to pouring gasoline on a campfire. It certainly increases the risk of disseminated disease and turning what could have been a mild pulmonary cocci, which did not require treatment, into something which now does require treatment and further evaluation. So perhaps if you are able to test first before treating with steroids, at the very least consider the diagnosis. So thank you for that question. Next question, also a very timely one. The World Health Organization has announced the recommended viral composition of next flu season's viral flu vaccines. What do we think might be the status of a COVID and flu combination vaccine for the upcoming flu season? So yeah, that's a very important question because of course fewer shots better than more shots, and also if one can have products which are successful in combining seasonal viral vaccines, that would be ideal. Current status is that Pfizer, Moderna, and Novavax have all started work on combination flu vaccines, harnessing for the first two, Pfizer and Moderna, the mRNA vaccine strategy, and for Novavax, they're a nanoparticle stabilized vaccine approach. Novavax will probably be a more traditional vaccine, so antigen-based, similar to the current quadrivalent flu vaccines, whereas the Pfizer-Modernas are more likely to be an exploration of mRNA vaccine strategies for both. But in the meantime, they're combining or looking to combine the mRNA COVID vaccine approach with a more traditional quadrivalent flu vaccine. Key point is that the messaging from all three companies is that they are looking at this and starting work on this. So in a usual time of year and decade and non-pandemic status, one might anticipate at least a year of creation, been testing efficacy, outcome, phase 1, 2, 3 trials, etc., before coming up with a valid and distributed product. However, as we all know from the early days of pandemic and Operation Warp Speed, the mRNA vaccines and several others were created very quickly. Certainly the existing technology is there, and those companies listed are no strangers to combination vaccine products. I think it's really anybody's best guess if we'll have a successfully tested and efficacious combination vaccine product available by the next flu season, which, as you all well know, would typically start immunizing sometime in September to early October. That gives us the summer of time to work at it. That's certainly a good 6 months or so, which is more than enough time in the rapid discovery days of early pandemic COVID-19. However, and this is a big however, as I think we all know, the amount of and intensity of federal funding for vaccine discovery has certainly dissipated, decreased significantly, and after May 11th will go away almost completely. So there may not be as much of a financial incentive for those companies to proceed rapidly. However, at least the messaging on all three companies' websites would suggest that they're aware that there is a societal need for such a product, and thus there is some urgency to proceed expeditiously, as the phrase might be. So keep your fingers crossed. I don't have any personal predictions for if we'll actually have a successful product by next September. I think it is possible. Whether it is likely, I think really depends on a whole bunch of things, including market forces, anticipated uptake in the community, and that's a big one as we struggle to get anybody vaccinated with anything at this point. But if all the stars align, etc., then yes, we might have that combo vaccine for the upcoming flu season. A related and corollary question is that a good idea? And I would say 100% yes. Certainly, we can anticipate COVID to have some degree of seasonality and or sort of an endemic approach as we do every year with influenza. So it makes sense to combine those two for the foreseeable future. Whether and if and how that happens, I think, remains to be seen. All right, great. Next question. March 1st, CDC announced an outbreak of extensively drug-resistant Pseudomonas aeruginosa linked to several artificial tear products with withdrawals of those products from the market. Yes, this is true, although not the first time of artificial tears being associated with infectious agents. The question goes on, does it alarm me that there's never been an outbreak of this specific strain in the United States? I would not say alarm specific to this outbreak, but every single outbreak of highly drug-resistant infectious agents is cause for concern, and that can be whether it's product-related or formula-related, and or just what's out in very specific communities. We talked last time, podcast, about the XDR, or extremely drug-resistant shigellosis, affecting specific populations, especially including men having sex with men, receptive anal intercourse, and other related groups. And that, of course, has potential to spread into the community and affect babies, children, pediatrics, etc., very similar to how monkeypox spread out of the MSM population and into heterosexual and pediatric population. So that's a little bit off target, but bringing it back to the Pseudomonas and the artificial tears, yeah, it's concerning, because what it means is that at some point in time there's a breakdown in quality control and the ability to create product which has potential to distribute infection in a sterile fashion. But this is not the first time, folks. I mean, there have actually been products such as steroid injections. You may remember that from a pharmacy that's on the East Coast whose practices declined somewhat and were able to distribute infectious agent via steroid injections, causing fungal meningitis. There have been a recent outbreak with several infectious agents related to formula. All these can be tracked back to a decrease or a lack of or a cutting edges in quality control by the various manufacturing organizations. And yes, it'd be lovely to lay blame all the way at the doors of the FDA, and in fact, some amount of supervisory ability of the FDA has been extremely curtailed by funding issues and previous federal governments going in different directions, if I said that politically nicely enough. But yet, there's still a lot of blame to be laid on cost-cutting measures in the commercial world of healthcare delivery, and that unfortunately is a great big fat horrible badness, especially in this country, where we have attempted and continue to try to profiteer from healthcare to human beings. And only once we get past that, I'm getting on my soapbox here, will we provide healthcare, affordable healthcare to all, can we maybe get away from this problem of cost cutting. Certainly we have to take the profit out of medicine, which is not going to be a popular opinion to some, those earning billions of dollars off the backs of others. But until we get to that point, then I think we will continue to see outbreaks similar to this one. For the current one, the artificial tears have already been pulled from the market. It remains to be seen if there are other other affected products. The products are certainly ones which could be used, although do not seem to have extensive distribution to Arizona, from what I can tell from the lot numbers and manufacturers. So, putting on the clinical hat, if you have a patient who has been using artificial tears or artificial eye drops of any nature, who has a conjunctivitis that seems to be refractory to the usual treatments, do consider Pseudomonas and refer to perhaps our ophthalmologist for a culture so that we can see if it is perhaps Pseudomonas. So, yet to be determined. Last question, and this is also a very interesting and timely one. HIV clinical practice guidelines are now incorporating breastfeeding options for people living with HIV on antiretroviral therapy with sustained undetected viral loads. And this, of course, is a significant departure from the previous guidelines, not guidelines, standard of care for people living with HIV and having new babies in parts of the world which are developed and have adequate alternate nutritional options. So the question is, given that this seems to be a direction that we're going, do I personally recommend breastfeeding in patients, mothers who are HIV positive with sustained significant negative viral loads or undetected viral loads and on effective antiretroviral therapy? It's a great question, and I have not completely made up my mind on this one. However, I will say that in the HIV/AIDS medical community, and certainly those patients who are living with HIV and even AIDS, that there is now increasing support for partnering and intercourse between disparate pairs. So a partner who is HIV positive and a partner who is not, if the HIV positive partner has that same set of qualifications. So on antiretroviral therapy and with an undetected viral load that's been stable. Varying recommendations for the HIV negative partner to take PrEP, so a pre-exposure HIV prophylaxis prior to that sexual encounter. And obviously that would be difficult to achieve for a brand new baby because the PrEP medications are not significantly safety tested in brand new infants. But the same scientific approach holds that if there is an undetected viral load, there, of course, the HIV is in a reservoir somewhere within that mother's body, but it is highly unlikely to be expressed in breast milk since the transmission of HIV via breast milk is already much more muted or subdued compared to perinatal blood exposure and body fluids. So, given that there are significant, as we all well know, significant benefits to nursing, to breastfeeding, and not just for maternal bonding, but actually increasing evidence would show now a very successful transfer of mom's microbiome, not from the breast milk, but from the periareolar area. The breast itself contains microbiome organisms, which the simple act of nippling, suckling at the breast, will transfer successfully to the baby. So the babies are getting their intestinal microbiome, their healthy, normal flora, not just from breast milk, but also from skin to skin or skin to mouth contact. So that's a significant benefit that depriving babies of does have potential deleterious downstream effects, including alterations of intestinal flora with immunotolerance mechanisms creating a risk for inflammatory bowel disease, for example. So that plus maternal bonding plus the colostrum benefits, IgA transfer later on, etc. and so forth, we're obviously all huge fans of breastfeeding. And if in a low risk situation such as this, mom is on antiretrovirals, undetected viral load, stably so during pregnancy, I do believe that it is scientifically and clinically okay for that mother to breastfeed. There. Yes, I get it out there. That's my belief. So that needs to at some point be tested in a long-term prospective trial, which will be a multi-center trial, of course. But in the meantime, I think it's a very reasonable recommendation to have and to discuss with the mother in a shared decision-making. Like, theoretically, there's a risk, of course, but that risk, theoretically, is minute. So go for it. So there you go. That's it for the questions today. In terms of what we're seeing out there, just as a brief heads up, the cases of COVID-19 continue to have sort of slight waxes and wanes, continue to still see the occasional child admitted with refractory croup that may indeed be due to SARS-CoV-2, and yet still seeing plenty of rhino/enterovirus, increasing numbers of adenovirus with associated rash, conjunctivitis, conjunctivitis, refractory multifocal pneumonia, hospitalization, etc. Human metapneumovirus is making a stand for winter virus of the week, month actually, and so there's plenty of that out there. And also an emergence of the non-SARS coronaviruses, but other coronaviruses as well. So still yet plenty of respiratory disease out there causing both bronchiolitis to viral appearing pneumonia, to fevers of unknown origin, to rashes, which get everybody all excited about Kawasaki's disease and everything else. But the last 3 patients I've seen for suspected Kawasaki disease in the emergency department have all been adenoviral positive and had findings compatible with that. Also out there as an FYI and heads up is still plenty of group A strep disease, both pharyngitis but also scarlet fever, and now in the last week and a half 2 cases of acute rheumatic fever diagnosed by Jones criteria and in 1 case by echo. So there is invasive and post group A strep rheumatologic immunologic disease out there. So definitely put group A strep on your radars if it isn't already. And unfortunately along with that will be all sorts of other post-viral bacterial infections. So H. flu pneumonia following viral disease, viral lower and respiratory tract disease is out there. And unfortunately an also significant increase in rheumatologic diseases, including several patients seen recently and locally with systemic onset JIA and also new diagnosis lupus. So boy folks, it's getting quite exciting out there as we start to calm down from our COVID-19 days. We're back to business as usual with a huge explosion of all those lovely diagnoses we have missed ever so much, or not, but they're coming to us. They're going to be coming to you in your practices as well. So heads up, have a very open mind to further testing. Running into difficulties, challenges, or questions, feel free to reach out to your colleagues and friendly consultants, because we're getting back into it, folks. Pediatrics is roaring in terms of health disease onset. So with that, thank you as always for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at AzAAP.org. And in the meantime, and as always, keep those questions coming. Hang in there. Heads up for the interesting stuff. Keep adeno, group A strep, and rheumatologic disease front in your mind. And if there are questions about that, send them my way. Thanks as always for your service. I greatly appreciate all of you.